Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
So hello and welcome everyone. My name is Renee Garrett and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Each episode is 60 minutes in length and will be offered for 0.1 ASHA CEUs. And so we have some financial disclosures and non-financial disclosures to get through tonight before we get started. Terresa Ross receives a salary from North Mississippi Health Services as a staff speech pathologist, and she does receive an honorarium for her presentation tonight or today on SpeechTherapyPD.com. Her non-financial disclosure is that she's a member of the Mississippi Speech Hearing Association, where she serves as university chair for the membership committee. My financial disclosure is that I work for a large health system in the Commonwealth of Virginia. I also teach adjunct in an instructor role at Old Dominion University and James Madison University, and I do receive an honorarium for hosting this podcast from SpeechTherapyPD.com. My non-financial disclosure is that I am the current secretary for the Communication Disorders Foundation of Virginia. So joining us tonight or today is Terresa Ross, MS, CCC, SLP. Terresa is currently the sole SLP at North Mississippi Medical Center, where she works in inpatient and outpatient settings, serving both pediatric and adult patients. She's been an SLP for 28 years, and she earned her master's degree in speech pathology from the University of Southern Mississippi in 1995. Her areas of focus include cognition, language, and swallowing disorders in adults. She is certified in vital stim therapy and certified in McNeil dysphagia therapy. So thank you for joining us tonight and welcome, Terresa.
Thank you for having me.
Absolutely. So just to kind of jump into settings, I think it's important for us to sort of talk about what settings that you've been in. If you've been in, when you say inpatient, are you talking about in acute care, inpatient rehab, or both?
So I'm at a community hospital, which is a satellite hospital for a larger system. Inpatient is acute care, but we also do swing bed. So it's not the inpatient rehab with the 3 hours of therapy in the gym, that sort of thing. But we do a swing bed, usually 2 to 3 weeks.
Okay. All right. So I started my career in inpatient rehab, and so I'm very familiar with that. And I still say it's my first love. And so same kind of thing. I went from inpatient rehab and covering LTAC and outpatient as needed to going into acute care. And I also worked in I worked in the trauma hospital first, which is woof. And then covered, because I was resource pool, I covered pretty much everywhere and anywhere they needed me. And then I went to the community hospital as well. But we had a 15-bed ICU and anything you can imagine. The hospitals in a rural area kind of started that way, and now it's sort of the up and coming spot in our city. And so you get just a variety of all kinds of stuff. Is that sort of how your hospital works?
Yes,
for your population?
yeah. If they're very, very sick, they're usually transported it's about 50 miles north of here to the big hospital. But we do have an ICU. I think it's a 6 or 7 bed ICU. But we see a variety of things.
Gotcha. How much of your caseload would you say is primarily dysphagia versus the run-of-the-mill other stuff?
Right now, not very much. I'm going to do a modified tomorrow. I did 2 yesterday. One was an outpatient. It just varies based on admissions to the hospital. I screen all the swing beds for swallowing, but I haven't gotten a lot lately. It fluctuates.
Okay. Yeah, I feel like that's all I did was dysphagia all day, every day, all day, run around the track, go to the ED, go to the ICU. Hope someone's awake, alive, those important things that awake and alive and breathing.
That helps. Yeah.
So I know you did a talk in Mississippi at your state conference, and so one of the things that I really wanted to have you discuss today was ethics and how that relates to dysphagia care, and sort of how we are as a field moving away from some of those practices that were ingrained in us, and as a less seasoned clinician, and what that looks like now.
So I kind of fell into this, and I don't claim to be an expert by any means, but I hate not knowing something, and I'm a sponge and a nerd. So
Love it.
So actually, it kind of started. I need to back up and kind of give some background.
Sure.
In 2006, I left the medical side of speech pathology and went to the schools because I wanted to be more on my children's schedule. My son was about to start school. I was working an hour away from home, and I wanted to be closer to home. And there were no medical settings. So I was out of the medical part of it from 2006 to 2015. And I was like, things had to have changed. The only thing in my toolbox in 2006 were tongue wags, K&G words, thickening liquids, maybe some DPNS because I went to that course too. And I just felt like things had to have changed. And I started digging in. And I actually had the good fortune to meet Ed Bice. He was a rep for Synchrony for ACP and came to our facility to teach us Synchrony. And he was very approachable. You could call him and ask him questions. So I started kind of following him on social media and Dr. Humbert around the same time and learning about, thicken's not always best. There's more to do than just these K&G words and puckers and tongue wags. So I've just been soaking it all in. And then I've tried to change the culture in my setting, not necessarily in the best way. Sometimes I'm like a bull in a china shop. So this course came about because of a conversation I had with a coworker. And it was basically, we're bound. We have to recommend the safest diet. And I'm like, but what's safest? And who says we have to recommend the safest diet? So I went down a rabbit hole.
Well, my favorite's least restrictive. That's my favorite. So
yes.
Go ahead.
And then I have a brother-in-law who's a medical malpractice attorney. And so I started interviewing him and bending his ear and really learned a lot.
That's smart because really, people don't think about what that looks like. And I said this not too long ago about when you work for the health system, you're sort of ingrained, if you ask the question, that you don't need to carry your own medical malpractice policy, and nothing will throw you under the bus quicker than your employer if they think that you did something wrong. So
exactly.
perfect person to consult with.
So that's kind of where the basis of the talk came from. So defensible documentation and ethical decision making. And it was really a conglomeration of ethics. I went to the ASHA portal and looked at our ethics, our practice policy, all of those things. I went to my state practice act. I interviewed my brother-in-law. And then I used 2 articles that really kind of helped me pull things together. One was the O'Keefe article recently, the newest one, informed or misinformed consent and use of modified texture diets in dysphagia. And he and Paula Leslie really talk about shared decision making and what informed consent looks like. And then I kind of brought in also the Palmer and Padilla article about how to break down and do a risk benefit analysis because some people do need a thickened liquids or need modified diets. This isn't me saying nobody needs thickened liquids. Everybody gets a choice, obviously, but we have to balance the informed decision making with a risk benefit analysis, I think.
Yeah, I think that's great. And so just from the ethical standpoint, I know for me, there's been many times where, I felt like I was sort of thrown under the bus because it was the last ditch effort to prove to the family that maybe we needed to look at comfort measures or hospice care versus aggressive measures. And so I sort of became, sometimes I felt like the scapegoat of, oh, well, if you do this modified on this patient and you can just recommend a diet, this will all go away.
Uh-huh.
Or if you do this modified and you can not recommend a diet, this will also all go away and we can just make them comfort care or go home with hospice. And yeah, so I felt, oh gosh, I got to the point, especially during the pandemic, where every time someone with COVID got admitted and they coughed, it's like, oh, let's get a swallow eval. And I'm like, for the love of God, really?
Not every cough means they're aspirating. Not every pneumonia diagnosis means they're aspirating. But I worked in outpatient before I came here in adult neuro, and I have so many patients who came to me on very restrictive diets from acute care because people are so afraid of aspiration or penetration.
Mm-hmm. Or they're afraid to speak up and say, just because we think this is what's happening, this is maybe not. Because what I ran into was, there was a time when I job shared with someone who was more experienced than I was, and we meshed very well and could bounce ideas off of each other because we weren't typically there at the same time. And so we developed this sort of like trusting relationship of, if I recommend this, I know that you'll follow up and with the family if they're not there, if I worked a weekend or whatever it was, and vice versa. And then someone new came in who was like, well, I don't think anybody should ever have a DOBHOF. And so in the community hospital, we didn't have access to instrumentals on the weekends because the radiologists refused. So it wasn't a me problem. It was a systemic problem that was out of my control. No matter what I advocated for, they were like staunch, absolutely not, because I'm going to go sit in the dark room and read that MRI and good luck with your whatever you got going on.
Right.
So when I had a new colleague start that was very inexperienced in acute care, really no experience, and she started doing instrumentals, if she worked a weekend, she would say, oh, well, I just can't advocate for this person getting a DOBHOF for the weekend. Let's put them on honey thickened pureed because that's the best thing to do. And then I go and do the modified on Monday, and this lady is younger than me and perfectly normal swallow, and just, she had not eaten all weekend, so now she's dehydrated and she's PO'd because
because she couldn't. Yes.
So, I think a lot of us ran into those scenarios that ethically was challenging, but also despite our best efforts and our research backed practices, we were just getting hit from all different directions from a variety of people who, there's a power dynamic in the hospital and we're not on top of the food chain. And so I felt like there was a lot of boxing going on,
Yes.
just trying to get after it. And then I'm getting fought from multiple different areas. Is that sort of the same scenario that you feel like kind of happens in acute care?
I think it depends on places. I will tell you that in my state, there's a lot of very conservative recommendations made. And we use a lot of pudding thick, honey thick, pureed diets around here. We recommend, and I say we, it's my state, PEG tubes for aspiration risk. Yeah. Putting geriatric patients on thickened liquids because of penetration, because we're trying to cover our tails, I think. And a lot of times my patients tell me they didn't have a choice. That's kind of why I went down this rabbit hole with this course, this talk. Because I was the same way. That's what I was taught. If they refuse the diet, they come off therapy. We wash our hands of them. And that's not how it should be.
Right. And I guess too, that it's been great that the literature and the research is supporting more of an ethical base and a shared decision-making process. And like you mentioned, informed consent. And we've had some people in our field who are vocal too, not just doing the research, but also promoting what they found out and making it accessible for those of us that are sort of in the trenches. And I, like you, I don't have my BCS and recorded with someone else recently who does. And I said, it's funny because when I came out of graduate school, I was like, the thing that I really didn't feel passionate about was swallowing. I mean, I did fine in the coursework and I did fine learning all the things. And the first thing they did when I got to IPR was send me to fee school. I was a new grad in August and they sent me to fee school in December. And so I was fee school at the same time I got my C's. It was quite an eye-opening and scary experience because that's not, I've always been more of a cognition and language based in my soul. That's what I'm passionate about. But I found myself, in a position where I had to be both because of where I worked and because of the areas that I chose to be in, like acute care. It's just dysphagia heavy all day long. And so you really do, if you're being a clinician who's up to speed and ethical, and you really do have to keep up with the research and you really do have to look at those ethical considerations. And again, those newer models they're really not new. Shared decision making is not new, but it's new, I think, a new hot topic in our field.
Yeah, absolutely.
And so what are two things that I think ethically, what are two things that you would consider ethical considerations for dysphagia treatment and evaluation? And it can be specific to setting or not.
Well, and so in acute care, I mean, you've got some really sick people. And so my talk is not usually around those in the ICU. I don't touch ICU patients usually. That's not who I'm talking about. I'm talking maybe your people on the general floor who are still fairly stable, outpatient, SNF. I think we have to look at more than just that box on the swallow study that says aspiration. We have to look at the whole person. I mean, all these courses talk about, well, Dr. Ashford's 3 pillars of aspiration pneumonia. What's their oral care like? What's their immune system like? How much did they aspirate? And we have to give them that. We have to give them that information. We can't just say you aspirated on the swallow study, you might get pneumonia. We have to say, look, you have these comorbidities. You have COPD, which puts you, we already know that disposes people to dysphagia, silent aspiration. I think we have to lay it out without the coercive language, without the scary language. I can't tell you how many people have come to me. Well, she said I'd get pneumonia. I can't handle pneumonia. We have to be unbiased. We have to be information givers, information sharers, and not coercing or pushing people to agree with what we think they should do.
Oh, I think that's excellent points because I know I definitely changed throughout my practice from saying I recommend XYZ diet to saying this diet looked like it might be the best, but explaining, especially when you're doing a modified barium swallow, explaining that that's a snapshot in time. And so we've got to look at like you said, the whole person and what was the residue like? Did they have residue? Were they able to clear with a maneuver or a second swallow or effortful or whatever it is we're looking at? And are we looking at that? Because there's still a ton of people in acute care who are not doing that on their modified barium swallows. It drives me nuts now that I'm an outpatient because I send them to people that I feel like I have faith in, and I send them an email and say, this is what we've been working on. Please do X, Y, Z. And it almost never fails. That's not what happens. And it's infuriating. And then the other thing I think that you sort of touched on and triggered something for me was that I started explaining it as I can make recommendations all day long, but ultimately this comes down to you as the patient and what you want and what your quality of life needs to look like for you to be happy. And I can give you this education, these recommendations, and I'm going to support you either way, whichever way you want to go. I'm here for you. I'm not here to say you will do this. It's my decision or my ethical consideration to say this is what I think is best, but this is also what we know. How many times do we see for an outpatient instrumental, we have head and neck cancer patients come in all the time who aspirate the crud out of all the things. I have one on my caseload right now. He has had a peg tube for a year. He's finally started doing some comfort feeds at home. He's been drinking Finn this whole time. Oral care is good. He's had some complications. We're going to go for a repeat MBS in a couple of weeks. But guess what? It's been a year and he's been doing things and he'll tell me, I did some stuff this weekend I probably shouldn't have done. I'm like, hey, man, if you're happy, I'm good. You haven't had pneumonia. He has not
Right.
had pneumonia
Exactly.
in a long time. And again, like you mentioned, looking at the 3 pillars, he had cancer. His treatment has been finished. He's completed that. He's mobile. He drives. He works in his yard. He's not got a ton of other health concerns and issues. And so his risk factors strictly from just aspiration are pretty low. And, fingers crossed, we've been pretty lucky up until this point. But he's not the only patient I've ever seen exactly in sort of that same thing where they're recovering from head and neck cancer and they've got some lymphedema and some trismus and some fibrotic tissue and they're seeking, he went and had some lymphedema management done and it made a world of difference for him. So yeah, I think it's just, I don't know. Swallowing was never supposed to be my jam.
Me either. And I think do you know how I have so many ECEUs over the last 5 years, and I feel like I could be a BCS because I'm like, I trusted what I was taught by the language specialist taught my dysphagia course over a 5-week summer. But I was a follower. I did what my supervisors and my coworkers who had more experience than me told me to do those first 10 years. Journals weren't accessible. There was no internet. And now that there is, I'm like, I am soaking it up because I don't like feeling like I don't know what I'm doing.
Mm-hmm.
And there's got to be something more to help these people swallow better than stick your tongue out 10 times and wag it from side to side and say cupcake. So, and I think it behooves all of us to stay up to date. We can't keep doing the things we were doing 30 years ago, 20 years ago. Our patients deserve better.
Yeah, even 10 years ago.
Yes. And I don't want my coffee thickened. I will go to my grave aspirating on my coffee with my creamer without any thickener in it. And I think I owe that to my patients.
That's what I say about my wine.
That too.
Yeah. And again, I think that ethics is part of it, but it's also, for me, it's beyond that. It's more like even beyond holistic, like being humane and being an active listener, because again, I touched on head and neck cancer patients, but we also have our progressive neurological patients with Parkinson's and Huntington's and ALS who come in. And I mean, a lot of the patients I've seen for Parkinson's, I used to call them the repeat offenders at the hospital because they would come every 2 to 3 years with an aspiration pneumonia. However, do we really know it was aspiration pneumonia, or because you got that label because you aspirated like a micro or silent little half of a teaspoon of nectar thick liquids? Was it really aspiration pneumonia or was it just pneumonia? And now you've been with aspiration pneumonia. So every admission you get when you have an infiltrate, now it's all of a sudden aspiration pneumonia because this label is following you for the rest of your life.
I've got 2 of those on caseload right now. And I honestly don't think it's aspiration. Their swallows look beautiful. And here's another thing where information and shared decision-making came in, because the O'Keefe article talks about not only are we obligated for them to be able to make an informed decision about their treatment, but they have to make an informed decision about any tests or procedures. So this patient I had today, I'm talking with his spouse. He has Parkinson's and dementia. I said, we could do a swallow test because I don't have x-ray vision. He's not, I don't see anything that just jumps out at me at bedside, except for the fact that he has the diagnosis of Parkinson's. Okay. So if you wanted to do an instrumental swallow test, we absolutely could do that. But here's the thing. The results I may have to make recommendations about changes in diet, or there may be a discussion about not eating by mouth. And she goes, he's already made that decision. He won't do it. We think quality of life is more important. I said, absolutely. We won't do the test. And I felt great about that.
And you should.
They've already talked about it. And where, might be pushed into at another facility, pushed into having an instrumental because we're not sure. And then, God forbid, there's a little bit of aspiration or penetration and a diet change would be made.
I saw, what did I see the other day? Moderate silent penetration to the cords. And I went, what? What are you talking about? That's not actually a thing. No, it's not a thing. Stop putting that in your notes. Because
Yeah. Well, and here's the other thing, and this was not in my talk, but I think ethically too, we need to be all using standardized language
Mm-hmm.
and assessments, because nobody where I work uses the PAS score. We don't use
What?
the PAS.
Oh, yeah, no,
Nobody,
what you said. I was just reiterating the what.
nobody uses it. We get penetration aspiration to the cords, all that. But we don't even use standardized documentation or language or jargon or whatever about the physiology. There's no physiology mentioned. And I think that's what's so wrong with where Swallow is right now. It's so fractured.
Mm-hmm.
And I think it's because the research hasn't been as accessible. Like I said, I graduated in 95. Internet wasn't a thing. And then we have people, it's easier to do things the way we've always done them
Sure.
than to change the way we do them.
Mm-hmm. Yeah, it's like the routine. The people who sit in the same pew at church always sit in the same pew at church. For humans are creatures of habit, but when it comes to our patients and best practices and care, we can't be habitual, because in the medical realm, things are always changing. Research is always being conducted and being published and coming out. And I will say it's a lot more accessible now than it was even 5 years ago. Most of us that work for a health system or a company, if you do any kind of adjunct work at the university, you can request articles through the library at the university. You can request through your health education person at your health system. And so I think that's a really great resource that a lot of people don't know about. We just happen, because we're the largest health system in the state, we have someone who sends out emails and says, hey, these journals have just come out. Is there anything you want me to get?
Wow.
But most of the time it's like AJSLP, and I'm like, I can get that any day of the week. So.
Right. Well, and
But
we have a librarian, and I have accessed a number of articles through her. I've even started a journal club that meets every other month.
Oh, that's cool. Very good.
With limited involvement.
Well, you're making an effort. And MedBridge too, I know our health system pays for us to have an affiliate membership for we're required to do so many for our stroke certification for our hospital. But there are some decent-ish enough courses that do have resources that we have access to. If your employer does have any sort of CEU access to things like that. And again, thinking about just the shared decision-making model and informed consent. So I think it takes me back to when I first started doing fees, and informed consent was always a thing, because we had this piece of paper that had the contraindications, what the test entailed. We went through it with the patient and the caregiver, whoever, if they had a medical POA or whatever. We had to go through this every single time that we were going to do a fees. And not only do we have to go through it and have it signed, it was a separate consent from the general informed consent that the patients did when they got admitted to the hospital or to the rehab unit. And so we had to do that, and it had to be witnessed by, a nurse or another PT or whoever happened to be in the gym and could listen to the spiel. And so that was my first introduction to informed consent. And so when this started sort of becoming more prevalent, I think in the literature and in the talks that I've been to about dysphagia, I wasn't surprised, but there's so many people who are so completely unfamiliar with the term and also what that looks like. So is there something specific that, as far as documentation goes, is there something specific that you do or that you recommend that other people do?
So my brother-in-law, and actually Hillary Cooper, I did a course with her with Med SLP Collective, and she has a template that I kind of use, and I talked about it with my brother-in-law, and the O'Keefe article talks about it too. There's really not a form. Informed consent is not a form necessarily. It's a process, and so I just, like I said, I interviewed my brother-in-law, so I just jotted down some stuff, and I said, so I gave him this scenario, a hypothetical scenario, and I wrote out what I would tell the patient, and he said, it's a good start, but it's not enough. So I tweaked it. So basically, what you would do is tell them, this is what happened on the instrumental. Here are your particular risks for aspiration. You have COPD, or you have reflux, or you have poor oral care, or list all the things. diabetes or kidney failure. Here's some possible recommendations. Thickened liquids or not thickened liquids, modified, or, all the possible recommendations. Here's the risks of those thickened liquids that we have to think about in light of your kidney failure or your recurrent urinary tract infections or those kinds of things. Here's the benefits of all these things. Where would you like to go? So, it's really a lot more than you can put on one form. In my opinion, I think it's like a conversation, but you do need to document that you've had this conversation, what was shared in the conversation, and then what the patient chose. And in the O'Keefe article, he says, patients have the right to change their mind.
Mm-hmm.
So just because they decide to go with this diet, possibly that maybe you recommended, they have the right to change their mind after they've tried it, and if they don't care for it. So that's something else I think we should also document. We can try this diet. If you don't like it, we can discuss modifying it. But it's really, if you were going to put it in a form, it would really be kind of lengthy, because you really do need really, because if we're going to look at all their comorbidities, like the Palmer and Padilla article talks about, and the Langmore article, what are their comorbidities? CHF, all these things, like the Langmore article said, these other things predispose people to aspiration pneumonia significantly more than just aspiration alone.
Right.
And then, what's their mouth look like? Can they brush their own teeth? Are they mobile? All that has to be considered, and we need to tell them that.
Are you taking advantage of our new amazing feature? The certificate tracker. The free CE tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah, and I think that I know Hillary pretty well, and I went to her talk, and I've been to a couple of her talks, and one of the things that she talks about too is documentation, like putting people's names and quotes that they said, and I've done that too. I've actually I got called into one of my manager's offices for putting a quote from a patient's family member in a document in the EMR, and she was like, "That's not the appropriate place." Absolutely, it is.
Yep,
Covered
all of them,
but because that's what they said, and so here we are. But then also, the shared decision-making process to me should have always been a thing. And so it feels like we sort of were this like dictator of like, you will do all the things. And now it's kind of, we're moving away from that, which is great. But at the same time, I think there's so many physicians and nurses who have this mindset of thicker is better. If the speech pathologist isn't here, let's do honey thick liquids because that's better. And we definitely had a physician who would be like, yes, honey thick and pureed for all the people. And I'm like, the lady's 101 and she can't even sit up in the bed. She doesn't have any teeth and she's been fine. She hasn't lost any weight. She doesn't have any pressure ulcers. She came from long-term care. She's been cared for very well. She's not malnourished. She's here for something completely unrelated. And at 101, if you're aspirating and you got all that other stuff going for you, who gives a crap?
Exactly.
Let grandma live.
Well, and it just goes to prove that they don't read their literature either, because there's a lot in the medical literature about that aspiration pneumonia is more than just aspiration. So I don't think any of us are reading our literature.
Well, and I think it also speaks to, so I taught an aging class this semester at James Madison, and it was about normal aging, but we actually read a book that was written by a surgeon who is sort of, and this is it was 2014 when he wrote this book initially, and it's so relevant today because it talks about geriatric care and the expectation of the fix-it mentality of that we're going to be able to fix all these things that are wrong, and not that we're going to be able to support this aging population who, they may have some diseases like COPD or like CHF or even dementia that aren't exclusive to causing aspiration or contributing to. It's more of the holistic picture, but then also what are we looking at as far as all the other things that are more important, like fall risk and being alone and not having access to food and not being able to get their medications that are vital for their well-being. And so there's a lot more to it when we think of our geriatric patients, and then also our stroke patients, because well, gosh, I've seen a ton of miraculous stories throughout my career. There was a lady, and it's funny because IPR, for some reason, the patients I saw, I don't know if it's the length of time they were there, the amount of time I spent, the place that I was in my career, and just needing to do that research constantly to make sure I was up to speed and doing best practice. I guess it's all of the above. But we had a lady who came in and wound up on my caseload, and for all intents and purposes, they had called LifeNet to come and harvest her organs. They were taking her off of life support. That before she came to us, obviously in IPR, the expectation was that they would take her off the vent and then she would expire, and they were gonna. LifeNet was there. Well, they took her off, and she started breathing on her own.
Oh, wow.
She had a peg and was able to. She did have instrumental. They weren't great because she was weak. She'd been recovering from the stroke for probably about a month. And by the time she got to us, she was doing better. She wasn't great. She didn't have, every day wasn't a great day. She had some kind of mediocre days and some days where she just couldn't. Which is, again, when you work in various settings, you see that, that our patients aren't from our productivity standards make it look like they're mean to you, and they're like, hey, yes, I will participate for an hour today, and that's not how this works at all. And so I think that I want to say she'd been in our spot for like a week, and I did a fees on her, and guess what, she didn't aspirate anything. She wasn't even close. She didn't even have residue, and it was just a matter of her rehabbing, bouncing back, gaining the physical strength, gaining the mental stability of not being sedated on the vent. And, that muscle atrophy occurs so quickly, but she was probably late 50s, early 60s. So she wasn't old by any stretch. And she was able to really rally and bounce back and start to participate. And next thing you know, she's eating and wound up going home with her daughter after like a 4-week stay. It was one of the most incredible things I've ever seen. But had everybody just sort of dropped off and not said, hey, like the people in acute care advocated for her to go to IPR. They really wanted to send her sniff, and they were like, she's too young. She's done all this so far. They really like stuck to their guns, and thank goodness they did, because I don't think, had she gone to a different setting, I don't know what would have happened. And I don't know, she wouldn't have had access to instrumentals back then. This was in 2010. She wouldn't, or 2010, 2011. She wouldn't have had an easy access to an instrumental at that point. So it would have made a difference if they hadn't looked at the holistic care, the ethical standpoint, the sort of best practice of what may give her foster the best patient outcome for this patient. And so I never forgot that. It's always kind of stuck with me. And I sometimes will think about that when I have a tougher case where, again, a lot of times in acute care, I feel like we're backed into a corner, and from a lot of different perspectives, be it family, be it physicians, be it nursing or whoever, or combination of all of that. And so I think when you have those couple of stories that you can go back to and gain your strength from to be an advocate. Let's be honest, sometimes being an advocate all day long is exhausting.
Oh, it's very exhausting.
It's exhausting. And I think we don't want to give up, but at the same time, some days it's like, oh my God, how much more can I do and take? And then again, we got to take ourselves out of the picture, but some days it's hard to do that.
It is. One of the things too I wanted to mention before we got off here. So not only is informed consent our ethical responsibility, it's the law.
Yeah, it is.
And I had not heard of that law until like 3 or 4 years ago. So I know a lot of people don't realize it, but it's federal law. And when I went digging through, like I said, I went to the ASHA Code of Ethics. I even printed it off. I have it here. So it's like safest diet. What do we have to do for a safest diet? It doesn't say anything about diet, but it does say we have to provide informed consent.
Mm-hmm.
And that's what my State Practice Act says also.
Mm-hmm.
So when I started looking up informed consent, then we have the Patient Self-Determination Act. And so people can get in big trouble for not providing informed consent. And some people go, well, we just make the recommendations. The doctor orders it. Well, most of the doctors where I'm at do what the SLP says.
Yeah, same. Very few don't.
So that's a cop-out, in my opinion. If you go, well, I just make the recommendation, the doctor orders it. That doctor, he just signs off on what you put there.
Mm-hmm. Yeah, because most of the time I'd call for the order and they'd be like, whatever you think. And I'd be like, no, not whatever I think. This is what the whole thing is. And they're, I'm in a hurry. Well, that's great. I'm in a hurry too, because I got 25 patients on my caseload and it's just me.
Mm-hmm.
So great. I'm glad you're in a hurry. So am I.
Yep.
Or the ones where there was a couple times I'd get down to I had one patient that she had pretty, I wouldn't say advanced dementia. She's moderate. She had some appropriate social greetings, but her family was fantastic. And she's another one of those people that I saw multiple times in the same hospital. She'd come in, I call it the tune-up. She'd come in for her tune-up. She'd get a UTI. She's altered mental status from the UTI. And all of a sudden they're ordering a swallow a valve because she's altered. She's chewing her pills.
Okay.
As most everyone else with dementia. So there's that. And so there was one physician who I had already gone in on the weekend and met with the family. They knew me, I knew them. And I said, what are y'all thinking? What do you want me to do? They're ordering this. They want her to have a modified barium swallow. And the daughter's like, absolutely not. She's altered from the UTI. And once she bounces back, they were already doing, this was before IDDSI. They were already doing like a in between a chopped and a ground diet. And she was on thin liquids. She did it via straw because she had some oral containment issues if she didn't use a straw. She had a UTI. She wasn't there for pressure ulcers. She wasn't there for malnutrition. She wasn't there for all these other things. And so the doctor sort of like force fed, put the order in for the modified barium. And I called him because the nurse calls me and she was like, what the heck? This is exactly the opposite of what you said and what you recommended. Again, shared decision-making, informed consent. The family said, no, thank you. And I was like, yeah, absolutely. And so what happens, we get down to the fluoro suite because he's adamant. He hung up on me. I was so mad. I was like, I know he didn't just hang up on me. But I get down there and guess what? She is demented. So she's in a new place, new people, new lights, uncomfortable chair, all this crap with barium. We're trying to shove it in her face. She doesn't want it. She's pushing me away. She's refusing to open her mouth. And, when I have a patient like that, I don't force that anymore.
Oh, no.
When I was earlier in my career, I felt like we were sort of like, keep going, keep trying, keep trying. No, because if she's giving me all the buying signals that she's not having it, I'm not going to do that and torture her. That's just wrong. And to me, unethical is crap.
Yep.
I call him from the fluoro suite and I said, this is what's going on. And he was like, okay. And I said, well, I'm requesting your assistance because you were adamant that we do this test. So I would like for you to come down to the fluoro suite and see if you can provide assistance. And he said, no, thank you. And so when it all wrapped up and I said, we continued for another 5 minutes, she continued to refuse, and rightfully so. He said, thank you for your valiant effort. And I was like, thank you for now being on the list of, now I hate your guts. Give me, Lord. But I mean, that was one of those situations where I felt like so devalued. And like, even though I came in with the right mindset, I did all the things that I was supposed to do. And for me, those are some of those ethical considerations where we get someone who isn't as skilled and knowledgeable and doesn't know what else to do. And we're sort of, again, that last ditch effort of, oh, well, let's just put it off on speech. They'll figure it out. It's incredibly frustrating.
It is very short. So I think we're the garbage can profession sometimes. They don't know what to do with them. So cognitively swallowing, whatever, we get them. I had a thought and I just
It leads into like advocacy too, of advocacy for patient rights and advocacy for all of the things we've already talked about. Because for patients with dementia, whether it's moderate or advanced, maybe the person has some verbal communication that's more automatic. Maybe they don't. But if they do have family that are actively involved in their care, or
exactly.
they're living in the person's home, or vice versa, do we see some really awful cases of that, where there's some neglect, or just some, I won't say, it's not always neglect. Sometimes people just aren't capable and they don't understand what that caregiver role looks like, and they feel pressured and they feel like they are obligated to provide care when they really aren't able to and don't know how to. But then we also get those families who are like, oh my gosh, they do a phenomenal job. They're just so great about advocating for their family member, and they're so great about informing us. And a lot of times I'll say, I'm so thankful that you're here, because I've just met her, or I just met him, and I don't know what their day-to-day life looks like. So
Right.
can you tell me, like, what do they normally eat? And you know what they always say? What do they always say? Oh, they eat regular food.
Yeah, no.
Yeah, I got really detailed about, I guess it's been about 6 or 7 years ago, and I started saying, oh, okay, so do you chop it up with a knife? Is it finger food? Do you put it through a blender or food processor or some kind of food chopper? And then all of a sudden you get, oh yeah, she eats mashed potatoes and applesauce.
Mm-hmm.
We
Cheese puree. Yep.
Yeah,
But, and I think we need to know our literature, and we need to know our evidence when we talk to our physicians. And I think that's the language they speak.
Mhm.
I put myself out there. I had an outpatient, and he was an 80-something-year-old, complained of getting strangled occasionally when he drank and ate at home. Walkie-talkie, lived at home, independent, still driving, completely with it, had a swallow study, and he had a little bit of aspiration with thin liquids. He had a cough response with the thin. He did not have a cough response with he did aspirate nectar. No cough response with nectar. Had a cough response with thick. The recommendation was for honey thick, because that he didn't aspirate on that. So he came for outpatient therapy. I provided informed consent. I'm like, do you like the honey thick liquids? No. Like, okay. So we tried some things, and he actually did better with larger boluses of thin than smaller, probably because of his sensory input.
There
So
you go.
we did some effortful swallows. And he was sent to see GI. Oh, I know why he was sent to GI. I wanted to make sure he didn't have any esophageal stuff going on, because he was describing what could have been like UES dysfunction to me. So the GI doctor says, if he fails his next swallows test, we may need to consider a PEG tube. I'm like, oh, no. So I sent him this letter, and I sent him literally a stack of articles. And I talked about how PEG tubes really are not appropriate in people that age, and blah, blah, blah. He called me personally. He was a little put out with me, but by the end, but basically I said, were you familiar with this research? And I said, because I told him we need to stop putting PEG tubes in people because of an instance or two of aspiration. PEG tubes don't prevent aspiration pneumonia.
Mm-hmm. I wish I had $1 for every time I said that. I could retire.
But we need to know our research before we go advocating with our doctors, because we've got to have reasons. We have to have concrete evidence, and there's a plethora of articles we could share. I keep articles in my my binder and my clipboard at work to share with other people, because I don't want it to sound like I just made this stuff up. There's evidence for it, and we need to know it.
It's funny because one of the SLPs that used to cover for us, PRN, she had created her own smart phrases in the electronic medical record that had some of those same articles, and she would just dot phrase and pull up the title and the citation of the article and put it in her documentation. And so one of the managers was like, well, she shouldn't be doing that. I'm like, absolutely she should, because
Yeah.
if you've got a different doc, because I don't know about your place, but for us, we had doc changes like 3 times a week. So the weekend doc would be there sometimes Saturday, Sunday, maybe Monday, and tend to change doctors on Tuesday. So they got new internal med attending physicians on Tuesday. Sometimes then on Thursday or Friday, they would change again. And so, one, the families hate that. And two, it lends for inconsistency with the staff when you're trying to carry over recommendations, because sometimes what will happen is if you get a doctor who is either only there like a float or a locum doc or something like that, they may not be as familiar with the staff, and so oftentimes they'll come in and change the diet or make these other recommendations for instrumentals when we've already documented all this stuff about how that's not what the family wants, it's not what the patient wants. And again, I think if you have the research in there that they can then access if they're willing, is super helpful, because why not?
I think it also covers us.
Yeah.
And I put research, especially if it's a patient that I feel like is it's just a difficult patient. They got a lot going on. Or if I feel like the doctor is pushing something that that the family doesn't want and I don't think is actually necessary, I'm going to put references in my evaluation, justifying the reason that I'm making the recommendations that I've made. I absolutely quote Ashford. I quote Langmore. I quote McCullough. I quote O'Keefe. I even quote sometimes articles about why I'm doing the intervention I'm doing, or the diet possibly that I've recommended. It's out there. We need to be familiar with it. And smart phrases are a great thing. I keep documents on my desktop that I can copy and paste and pull into my evaluation.
Mm-hmm. Yeah, and that's same thing with the penetration aspiration scale. That's actually in our MBS documentation, and the only problem is it pulls up the number without
without a description.
Without a description. So typically, I will put that as my part of my documentation. But I just find that those, like you said, those medically complex cases aren't often so cut and dry when it comes to making recommendations, because we know that a kidney failure patient, a patient with dialysis 3 times a week, at their baseline, or maybe they are critically injured and now they are in dialysis in the ICU. There's all sorts of things that come up that we have to be considerate of. And I know in our ICU, in our little small hospital that I was at for a long time, 9 times out of 10, our patients were emergently ventilated, intubated and ventilated. And so they were on sedation and weren't appropriate because we couldn't even get them to wake up. And they'd be like, just give them some ice chips and make them MPO. And I'm like, just call me when they're awake and alert. How about that part? And you've weaned them off sedation that could kill a bull.
Mm-hmm.
Because if I go in and there's, or high flow, that's my other big love. A high flow nasal cannula patient who's on like 60 liters or maxed out and the respiratory rates in the 40s. What exactly do you want me to do today? Because again, breathing is important.
It trumps swallowing.
Especially in relation to swallowing. And I know in larger hospital systems where there's more oversight, greater staff, because staff shortages it's a thing. And a lot of people don't want that mentioned and don't want it talked about, but I'm sorry, it's a thing. And it's difficult to expect recommendations that are already iffy if you're backed into a corner, or aren't based in informed decision, shared decision, informed consent, all those things. If it's not based in that, then you're making a recommendation for someone that you really could impact their recovery or imminent death, really. And I think that's where we kind of got off track too, as a profession, that aspiration pneumonia became the big bad wolf of, oh, if you don't do this, you're going to die. And sometimes it's more like, oh, if they can't breathe, and we go in 14 pills and 2 cups of pudding, then they really might because they can't breathe. And high flow is high flow. It's flowing in, pushing
in.
to the airway. So, again, a lot of that is dependent upon physicians, staffing, oversight, who's carrying over the recommendations when we're not there. What other colleagues are there that may be a good, I call it the court reporter, because some of the PTs I worked with, and especially in ICU, they're great because they'll be like, well, I noticed that the nurse came in to give them their pills and they didn't set them up all the way and they were coughing, but also they turned blue.
Oh, not good.
So again, there's so many pieces to this, and it's just a lot for, I think, when you're the only person like you are and like I was, unless we had a weekend person covering or a half person who came for 2 hours if we had a need for extra coverage, it's really difficult to have that pressure on you all the time and to feel like sometimes you aren't being heard. So are there any, other than the literature and just like you saying bull in the china shop, because I kind of was that way too. Still like that now. I get in trouble a lot,
Me
outpatient.
too. Yeah.
Because if you come into the office and you lay down on the desk and you don't do anything after session 3, I really think after session 2, but we have a 3-session thing. Ethically, it's time to say maybe we should reevaluate you after you do a course of home health. So I think if you're making the appropriate recommendations that aren't necessarily a patient abandonment situation where you're just wiping your hands and saying I'm done, then I think that's a whole different thing, and definitely the appropriate thing to do.
I'm sorry. Did you ask me a question?
I'm getting to the end of the road. No, but I think anything that takeaways, I think, for the audience and things that you would recommend, just based on your experience and based on your talks that you've done now, I think would be really helpful.
I think ask questions. That's what I didn't do enough as a new grad. I just did what I was told. And I took, because that was the person who had been doing it longer, ask questions. I tell my students, ask me why I'm doing things, question why things are done. I thought thick and liquid modified diets, crushing meds, PEG tubes were benign interventions for my swallow patients, and they're not. If you're not sure, Facebook has been a source of information for me, but don't let that be your only source of information. Go and dig into the literature. There is too much available to us now to say, I didn't know that.
And there's so many people, like we mentioned, I think early on, who are very staunch advocates, who have done research, who have done talks. And you mentioned Ed Bice. He happens to be in my state. Always just accessible, willing to have a tough conversation. Will he provide the answer you want to hear? Not always, but he'll provide some thought-provoking things, which is how most people best learn, is to not necessarily be placated or say, oh, yes, this is correct. This is what it's more like, okay, how can I lead you to think outside the box and maybe also advocate for change, but then also advocate for your patients and advocate for yourself so that you do have the tools that empower you to be a better provider and keep all those things, like you mentioned, in the forefront of ethics and shared decisions and informed consent. Because I know what Hillary Cooper always says is the little diet waiver isn't going to hold up in court.
No. And she said that she's kind of changing. She when she makes her recommendations, she comes at it from an informed consent. So she's even tweaking her stuff now. But one of the questions, I did want to mention this. So when I was interviewing my brother-in-law, I said, have you ever been involved with a case where there was a speech pathologist? And he said no. His aspiration pneumonia cases were usually skilled nursing, and it was neglect. Well, people with PEG tubes, frail elderly people. And I said, well, if you did get a speech pathologist on the stand, what would you ask them? And a lot of his questions were, what evidence did you use to support this decision? So lawyers are going to know our research. We need to know our research.
Yeah.
Because if we do, and here's the thing, somebody may decide to sue us anyway, even if we provide them all the information. There are some suit happy people, but if we did our due diligence, if we document that we provided the informed consent and it's there in black and white, then yes, I may go to court, but I knew my stuff. I can defend myself. Does that make sense?
Oh, yeah, absolutely.
I don't think we can prevent. There's no way we're going to keep from getting in trouble or somebody being unhappy with us, but we have to know what we're talking about. We have to document it accordingly.
Yeah, no, I think that's perfect for what everything sort of wrapping up what we've been talking about. And so thank you, Terresa, for coming on today. And I just really appreciate you coming on the podcast as a guest. I like that this was I felt like a really productive discussion in a way to just keep people informed of the things that they need to be mindful of in their practice, because it's really not about us at all anymore. And I think we sort of had that mindset before of the, less seasoned clinicians. We have this weight on our shoulders, so we have to be perfect. And most of us want to be perfect all the time. And it's not really about that. It's about making sure the things that we're recommending are in line with what the patient wants, the family wants, the friends and loved ones that are supporting them, what they're capable of supporting, and bottom line, following ethical guidelines. So I think, any other last remarks or conclusions that you'd like to leave us with?
Nope. Just stay curious. Dig into the information. Find mentors. Don't say this is the way we've always done it.
Yeah. And I always tell my students, don't burn bridges, because even if I don't want to go get dinner or coffee with you, I may interview you or you may interview me for a job one day. And so even if you aren't best friends with your colleagues in school or your colleagues at your work setting, just don't burn bridges, because you never know where life is going to take you. So I think that's both really good takeaways. So again, thank you so much. And I look forward to seeing you again and hearing more about your talks and maybe seeing you at some more state conferences.
Awesome. Thank you.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.